Inshallah. Assalamu alaikum. Today with us is a very famous doctor, Dr. Saima Ahmed, who helped a lot of doctors in neurology. Dr. Saima Ahmed, the consultant neuroradiologist, diagnostic interventionalist in neuroradiology department, Lahore General Hospital. Today, our lecture about head CT, CTA, CTP, reading in acute stroke. Dr. Saima, thank you very much to share your knowledge with us. If any colleague has a question, he can write on chat, and in the end of lecture, we can ask Dr. Saima. Dr. Saima, you can start.
Thank you very much, Dr. Ahmed, for this gracious invitation and for this kind introduction. So I'll be talking about the head CT, CTA, and CTP reading in the acute stroke. So whenever we are talking about the stroke, we need to be fast. So everything should be fast as far as stroke is concerned. So in the last century is a game changing as far as stroke therapy is concerned. So first of all, before the 2015, it's all started with IV thrombolysis and non-contrast CT. And then after 2015, after the 5 major trials with the EVT in the first 6 hours, and then with the extended time window up to 24 hours with the 2 major big trials with advanced imaging. So it's really a game changing. But for the stroke physicians, for the neuroradiologists, for the radiologists, we want to keep the imaging as simple as possible. So everybody should understand it and interpret it very easily. So everything is started with 4 Ps as far as imaging is concerned. So P is for parenchyma, and P is for perfusion, and P is for pipes. Pipes are the blood vessels. And then, of course, the P is for penumbra. So penumbra is the salvageable brain tissue, and it's very important. And all of us are very much interested in penumbra because this is the tissue we are going to rescue. So this is a picture which I have taken from the Nature 2019, a very beautiful article. It tells us about the cellular effects of ischemia. So whenever the blood vessels is clogged with the clot, there is a reduced cerebral blood flow, and then there will be the lack of oxygen and glucose. And due to this, there will be the mismatch between the energy requirements and availability. And then eventually there will be the calcium excess, and it will lead to the apoptotic cell death. And at the same time, whenever the blood vessel is blocked with the clot, there will be the disruption of the blood-brain barrier, and then the inflammatory cascade is evoked, and eventually there will be the ischemic changes happen. So we are going to see these changes on our imaging. So the core we can see with the non-contrast CT, and the blood vessels we can see with the CTA, and this penumbra we can see with the MRI and also with the CTP. So actually we are talking about the Cs today. So first is the non-contrast CT. Non-contrast CT tells us about the core. And then the CTA, with the CTA we can see the extent and the size of the cluen, the site of the cluen, and the extent of the thrombus. And then, of course, we look at the carotids, and then, of course, at the collaterals. And we are also very much interested in the collaterals because recently we have seen the Mr. Clean late results in which I think in the World Stroke Congress last year in Singapore, and in which the patients were selected on the basis of the collateral scoring, and those who have the good collaterals have the better outcome. So this is again a diagram in which you can see that there is an occlusion of the left MCA, and the blue is the area which is actually the core, and then there is a green or yellowish area which is actually the penumbra. So the area of the penumbra depend upon the collateralization. So you can see the more collaterals the penumbra has, the slow will be the progression, and the more time we have to rescue the tissue. So basically the first line imaging, we start with a non-contrast CT. So here is the question that why we want to have the CT. Number A is to rule out the hemorrhage or alternative diagnosis, to look for the early signs of infarction, to predict the current infarct size, all of above, or we don't do CT, just perform the MRDWI. So I think in this question, the D is the answer, that all of the above are the causes for which we need the CT in the acute stroke imaging. So first of all, we need to rule out the hemorrhage, because if there is a hemorrhage, then we do not send the patient for IVTP or for the EVT. So this is the first line. This is an image with the large parenchymal hemorrhage with the intraventricular extension. So no therapy can be offered. Then there is an alternative diagnosis. Sometimes the patient comes with a stroke mimics. For example, this patient came with a neurological deficit and you are suspecting stroke, but when you did the CT, you can see that this is the dermoid here. So you need to look into the alternative diagnosis as well. Now, the early signs of the infarctions, which are, of course, very, very important signs. You can see these are written all here. So in this, you can see there is inattenuation of the gray and the white matter at the left basal ganglia. And then in the middle panel, you can see there is a hypodensity, which is in the right parietal region, which is M3 territory. And then there is an attenuation of the gray-white matter here. Also in the left basal ganglia, a little of the hypodensity here. And then it's a positive insular ribbon sign, and you always compare it from the opposite cortex because this is very important, and it depicts the insular cortex infarct. And then we have the very beautifully depicted dense vessel signs. Then dense vessel signs are not pathognomonic, but they are important because they guide you to look into the site of the occlusion. So these early signs of the infarctions are very, very important, and you need to look into them. Now, how we can improve the gray-white matter differentiation? Because these are very subtle changes, and it's not easy to pick them up. You can see that in the first image, it's very noisy. So it's very difficult. So how you can improve the noise? You can improve the noise by the multiple ways, by increasing the tube current, by lowering the KVP, or by the post-processing, that is by the iterative reconstruction. So it is very important that you should know that how you you can work with your software. So it's very simple that you can adjust your window level and the window width by sitting at your console. By pressing the one button, you can change these settings. So in the above panel, the normal setting is 80 by 40 or 80 by 20 usually we do, and you can see that here it is not so clear, but this is the stroke window with the window width and level of the 40 and 45 and 40, and you can see that it's very easy to pick up these subtle ischemic changes. Now, not only your own training is necessary or your fellows training is necessary, but your technician training is also necessary. If you see such kind of images which are asymmetrical, it is very difficult to pick up the acute stroke imaging here. So the technician training is very, very important. Make it sure that they do not send you such kind of images. Now, the dense artery sign, previously I have said that dense artery sign is not the pathognomonic, but it tells you or it guides you to look into the site of the occlusion. For example, this is the dense vessel sign. It depicts that there is MC occlusion, and then you look into this hemisphere. Now, dense vessel sign is important. It is more importantly picked up before the 6 hours because more RBCs are there. After the 6 hours, as more fibrin goes into the clot, it's very difficult to pick. Also, we cannot pick more easily at 3 to 5 mm. Slice thicknesses, we usually pick it up when the slice thickness is usually 1 mm. And then there is a distal vessel occlusion in which you can see the dot sign. So what are the other factors by which you can enhance your ability to look into the earlier signs of the infarction in the non-contrast CT? So it depends upon the vendor, age of the scanner. The more age your scanner is, the more noisy will be the picture. It depends upon the many of the settings like voltage, tube current, iterative reconstruction, which is the post-processing. Then on the slice thickness, always use the thickness of 3 to 5 mm of the slices because they are less noisy. If you use 1 mm thick slices, they are more noisy. Then the patient motion is very important. It's very important that you pick up the old infarcts at the same time when the patient came with the acute ischemia. And then the experience of the reader. Also, it is very important that you look into these images in the dark light. When we see the images on our phones or on our screens, then it is very difficult to pick them up. So why we need to see identify the early infarction? Because we want to know about the core. Why we want to know about the core? We want to know about the core because core is already dead tissue, and already dead tissue, when we have a large amount of the already dead tissue, there will be the increased incidence of having the symptomatic hemorrhage later on. And then we need to look at the aspects. The aspect scoring is a 10-skill scoring, which covers the 10 areas of the MCA territory. It was developed long ago and well established now. So these are at the ganglionic and the supraganglionic level. And you need to learn this. And there is a website which is www.aspectsinstroke.com. You have lectures there. You have aspect scoring, a lot of cases there. You can practice there. So we have MCA territory with the 3 deep points and the 7 cortical points. When you pick up any of the inattenuation or the hypotensity, you are going to subtract it from the 10 point, and that is your aspect score. So here is the question about the aspect scoring. You try to look into these images very closely. You can see that in the first image, there is a dense vessel sign. So you need to look on the right side. In the middle panel, there is no change in the basal ganglia. So there it is not involved. And here you can see there is a subtle hypodensity here in the area of the M5 region of the MCA. So you subtract this 1 point from the 10 point and your aspect score will be 9. So this is the way you do your aspect scoring. So aspect is used as a selection criteria. As far as the major big 5 trials are concerned, only the ESCAPE is the trial which used the aspect as one of the inclusion criteria, and they included the patients with a good aspect, like with the 8 and the 10, and they have the better outcome. As far as Mr. Clean is concerned, they did not include the patients on the basis of the aspect scoring. They include all patients, and they have shown that patients with a low aspect also have the good outcome after EVT. So it is already established. You can see by the number of in these articles that if the patients from the low aspects, if they are selected for the EVT, they have the better outcome. So we should not defer patients on the basis of the aspect scoring only. Now, next is the advanced imaging, which is really not advanced. It's already established. So it is CTA, and then later we talk about the CT perfusion and multiphase CTA. So the one thing is this, that prior to 2015, many of the studies about the endovascular therapy were failed. They were failed because they did not establish the vessel occlusion prior sending the patient for the endovascular therapy. But after the 2015, in these 5 major trials, what they did, they always established the occlusion of the vessels and the site before the endovascular therapy, and that's why it changes the game. It's revolutionized everything because we had a better outcome when we know what the site of the occlusion is and where is the occlusion. So why we use the CTA? We use the CTA because we want to demonstrate the site of occlusion. We want to know how long and how big is the thrombus prior to sending the patients for the endovascular therapy. If you are neurointerventionist, you need a roadmap. So it provides you a very good roadmap. And then, of course, you look at the carotid pathology. And because this is important, that you know that what type of arch you are going to face, and is there any carotid pathology or not, because prior putting the catheter, you should know that what type of the catheter you are going to use in the EVT, and or what devices should be picked up. So this is important. In cases when the heart is involved, we can also see the proximal pathology, like if aortic atheroma goes up and causes the stroke. So we can see all with the CTA. When you are going to perform the CTA, you should know the very good protocol of the CTA, and you always optimize the protocol of the CTA if you want to look any of these acute stroke imaging. So the protocol is about the slice thickness, about the coverage, timing, and the kernel, FOV, and the contrast. So the protocol is that you scan thin, but you reconstruct the thick MIP images. This is important. And then 120 kVp, if you try to do it at a lower kVp, it would be even more better, because the K edge of the iodine is low, so we can have the maximum density of the contrast at the low kVp. Then the coverage should be proper. As I have said earlier, that you have to cover from the aortic arch up to the vertex, if not up to the vertex, but at least up to the pericallosal artery, because you want to see the pathology all over. And then the timing is also very important, because you have to see the arterial phase. And sometimes if the timing is not proper, you see the venous enhancement, and you may confuse it with the arterial one. And of course, with the iodine delivery rate, which is 1.6 into 2 grams per second. So this is about the contrast, that how you change the contrast here, and how much flow rate, and about the quantity of the contrast which you are going to use. Then the post-processing of the CTA. So whatever we are doing in the acute stroke imaging, we should be very fast. We should not waste our time. So ideal is this, that you do the 2D imaging, and then you reconstruct the MPRs and the thin and the thick MIPS. You can also make the beautiful volume rendered images also, but all of this very much time consuming. So ideal is this, that you see the 2D images and make the thick and thin MIP images, and you try to see your site of the occlusion. It is sometimes when you make the 3D reconstructions, it is very, very easy to pick up the site of the occlusion, especially the distal occlusion. But it is always a time consuming. So whatever you are doing, do it fast. As far as MIP is concerned, you can use the 10 mm and 30 mm. And you shouldn't use thicker, more than 30 mm, because in that case, you miss the arterial phase and you can see the venous enhancement. But in these, you can see that with the 30 mm MIP, it's difficult to see the carotids here. So the ideal is 10 mm MIP, but you can also do with the 30 mm. You can play around with this if you know how to do it. So this is a case in which the patient presented with aphasia and the right-sided paresis, and you can see that there is occlusion on the MCA occlusion. This is with bone, this is with the subtracted bone, and these are again the reconstructed images. So all images are very beautiful, and you can very easily pick up the site of occlusion here. Of course, there are pitfalls in the interpretation. So the pitfalls are about the timing. The timing should be very important, because you see the venous enhancement and you may confuse it with the arterial one, because the veins are parallel to the arteries present, but they enhance late. And of course, you should know about the anomalies. And because this is again a very beautiful depiction of the circle of the villus. Only 60% of the circle of the villus are complete, rest is all variation. So if you are going to perform the neurointervention, you should be very good in the neuroanatomy, and you should be good in picking up the anomalies. So this is a case in which there is the stenosis at the MCA. On the contralateral side, there is aplasia of the A1 segment of the ACA. So you should be able to pick it up. You should not confuse it, and you should send this patient for the endovascular treatment. This is again another anomaly in which there is a basilar top occlusion, but there is a bilateral fetal type of the PCA, and there is another anomaly in which the single A2 rather than the two A2s. So too much anomalies in one patient. This is another patient who presented with the vomiting and the dizziness. And when we perform the CT, it was normal, and you can see that there is the slight kind of the stenosis here at the distal segment of the vertebral artery, and the raw data is showing the double lumen, which is the dissection. You should not confuse it with a hypoplasia, because after 2 days, the patient appeared with a large left cerebellar infarct. So it's important that you should differentiate between these. This is another case, and there is abrupt hypoplasia of the distal segment of the vertebral artery at the pica. And the compensatory, there is a dilatation of the opposite vertebral artery. So this case is different from the previous one. In this, it should not be confused with the dissection. So this is not stenosis or dissection. This is abrupt hypoplasia of distal part of the vertebral artery. This is another anomaly in which there is a duplication of vertebral artery. It is very rare. So you should be able to pick up all these anomalies at the same time. So what are the tricks? The tricks in the interpretations are, so in the post-processing, you should not look only at the axial images. You should always look at the coronal and the sagittal images also. Then the evaluation of the protocol is necessary. You should be knowing your protocol all of the time, and the training of your staff and the training of your fellows and the training of your own self is also very important. And as far as advanced imaging is concerned, one of the advantage of doing the CTP earlier than the CTA is this, that you can obtain the CTA from the data set of the CTP. But of course, there is additional cost and there is additional time is also needed in all this. Again, the previous one, because the collaterals are very important and collateral scoring is also very important. The patient who have the good collaterals, they are the slow progressors, and they are those patients who show the good outcome after the endovascular therapy. The patients who have bad collaterals, they are the fast progressors and they have bad outcome after the endovascular therapy. So the collateral scoring is very, very important. So in this case, you can see that there is nothing on the right side. So it appears to have the zero collaterals. But when you do the thick MIP, you can see that you can diagnose a few of the vessels here. So always use the thick MIPs because they give you the better clue of the collaterals. So already there are the different type of the methods are well established in the different papers about the collateral scoring. But the easiest way of the collateral scoring is a 4-point scale in which the grade 0 is the one in which there are no 0% filling, so the whole collaterals are absent. And then the grade 3 is the 100% filling. In between, there is grade 1 and the 2, less than 50% and more than 50% of the filling. So the patients who have 0% collaterals, they have very bad outcome after the endovascular therapy. And the good outcome or excellent outcome in the patients who have grade 3 collaterals. However, the patients with the grade 1 and the grade 2 collaterals, they can also show the benefit with the endovascular therapy, and they should not be deferred from the endovascular therapy, depending upon the presence of less collaterals. So again, this is the grading of the collaterals. So next is the multiphase CTA. So here is the box in which you can see the advantages of the multiphase CTA with the additionally the 4D CTA. So you can obtain the multiphase CTA and the 4D CTA data from the CTP. This is one of the advantages of doing the CT perfusion earlier, which is being done in the many parts of the world. So again, this is the multiphase CTA collateral scoring. So one in the arterial phase, then in the early venous and in the late venous phase. And again, you can do the practice here at this website. It is very good website for this. So again, it is already established. This I have taken from the paper, the 4D CTA you can obtain from the CTP data sets, and it's very easy to do. This is already established. Now, what else? When you do the CTA, the additional advantages of doing the CTA is look into the arch. So this is a bovine type of the arch. And when you have this kind of the arch, then you are all, you can choose your devices, you can choose your type of the catheters, and you can save your time, which is very important in the stroke therapy. And then of course, you can grade the stenosis, you can diagnose the stenosis and also do the grading. This is additional advantages of doing the CTA. These are the different type of pathologies which you can detect at carotid level. You can do the grading less than 50%, more than 50% stenosis. Then there is occlusion at the carotid, and then there is a floating thrombus. This is pseudo-occlusion, and this is flame shape is dissection. Flame shape is always the dissection of the carotid. So this is a case. This is not my case, but I have taken it from another doctor. If you see the blood vessels with the bone, there is additional, advantages, because there is elevation of the styloid process there, which causes the dissection of the left carotid artery. So the imaging of the vessels with bone is also advantageous. So what's next? The next is the perfusion CT. So there is ongoing long debate about the perfusion CT, that it should be performed or it should not be performed. So as far as EVT is concerned, that why we select the patients for the EVT. We select the patient on the basis of the hemorrhage, and then we have to define core and the penumbra. The problem with the non-contrast CT is this, that non-contrast CT does not tell us about the volume. To know about the volume or the core, we need to have CT perfusion, or it can easily be detected by the MRI. But the problem is this, that MRI is not available everywhere, and MRI is expensive, and MRI is also, it's time consuming, and it's very difficult to monitor the patients for the long 15 or 20 minutes, and it's not readily available. And CT is available everywhere, so best is to do the CT perfusion. So we need to do the CT just to look into the core, and also to select the patients after the 6-hour time window. So as far as advanced imaging is concerned, we have already talked about the non-contrast CT, CTA, multiphase CTA, and now we are talking about the CT perfusion. It's already established. So what you look in the CTP and in CTA, you look for the vessel thrombus and stenosis, you look for the vascular anatomy and the physiological process. The physiological process is basically the CTP is for the to look into the physiology, and then to see the core and the penumbra. And of course, if you do the CTP early, one of the advantage of the CTP, doing the CTP early, is this, that you can obtain the CTA from the CTP dataset. Of course, 4D CTA can also be done from the CTP. And then multiphase CTA, that can also be obtained from the CTP. You just have to push a button and the software do all this for you. So here is a case in which the patient presented with neurological deficits and the CTA with a speech disturbance, and I think there is a loss of the sensibility on the right side of the arm. And the CT is normal, and when the CT perfusion was performed, you can see that there is increase in the Tmax, and the cerebral blood flow is reduced in the left side, and CBV is normal. So it tells you that there is some problem on the left side. Now, if you do the CTA, which is this, that that you have to look onto the left side. So there was MCA occlusion at the left side. At the same time, there is ICA occlusion. So sometimes if you do the CT perfusion earlier, it can guide you to look into the site of the occlusion on the CTA. And this is very important as far as the distal occlusions are concerned, because you always miss the distal occlusions when you do the CTA early. But on the CT perfusion, you can easily detect the distal occlusions, which can easily be missed on the CTA. Of course, there are many disadvantages of the CTP as well, because there is additional radiation dose, there is additional contrast administration, additional costs, and of course, the total time of the image acquisition, processing, and interpretation is everything is increased. So how you do the CTP? You have to monitor the first pass of the contrast bolus. So what you do is this, you take the small amount of the high density contrast, and you give it with at a very high flow rate, and then you change the contrast after giving the saline flush. First, it goes into the arteries and then into the capillaries, and then it goes out from the veins. So you have to make the time density or the time attenuation curves. And then you calculate later on the different variables like the CBF, CBV, MTT, Tmax, and TTP. You don't have to do it yourself. Software does this for you. And again, we use the low KVP because the kH of the iodine is low, and you can have the maximum density of the contrast at the low KVP. So this is a very simple graph which I have made for you. So this is the reference ROI. And after the few blank images, when you give the contrast, it goes up into the arteries, and it goes down, and then like this. So this is the normal tissue, and this is the ischemic tissue in which it is even lower. And here is another, this is bolus. It goes into the artery. This is the peak, and then it goes out. Now the time which is taken between going up into the artery and then coming down is the time which is called the mean transit time. And this is the time to peak, which is the peak time within the arteries. And the area which is under the curve is the CBV. Now, if you know the MTT and CBV, you can easily calculate the CBF. Now, this theory is called the maximum slope theory, and there are, in the post-processing, it is already established that there are many other methods of calculating, but this method is the deconvolution methods, and other methods we are not going to talk about it because this is not the topic to talk about these methods. Now, the CBF is the cerebral blood flow. It's normally 50 to 80 ml per 100 gram of the brain tissue per minute. In the cortex and the basal ganglia, the demand is always higher, and it is usually controlled by the autoregulation. So in the case of the maximum dilatation, which is due to the autoregulation, there is a decreased perfusion pressure and cerebral blood flow is decreased. So when it is less than 20 ml per 100 milligram per minute, the patient experienced the neurological deficit, and there is electronic shutdown, but still the changes are reversible. But if that goes down below the 10, then not only there is electric shutdown, but there is a pump failure. And if it happens only for 2 to 5 minutes, the change would be irreversible. So the next is the cerebral blood volume. Cerebral blood volume is the percentage of the blood vessels in the specific volume of the tissue. Again, its demand is higher in the cortex and basal ganglia. It is affected by the changes in the autoregulation, dilatation, or constriction of the vessels. So what happens in the core and what happens in the penumbra? Cerebral blood volume is either normal or it is higher in the penumbra, but cerebral blood volume is lower in the core. So we have to look into this, that what are these variables in the core and the penumbra if we compare core with the penumbra. Cerebral blood flow is reduced both core and in penumbra. Cerebral blood volume, it is reduced in the infarct core, but it is either normal or it is slightly increased in the penumbra. And then mean transit time, it is obviously it is raised both in the core and the penumbra, and the ratio is also higher in the infarct core. So this is one of the figure which is taken directly from the post-processing. Directly, it's a software. So you can see that there is a Tmax, and its Tmax is higher, and cerebral blood flow is the lower, and the volume is preserved. And you need not to calculate anything. It is directly telling you about the penumbra and the infarct by doing their own calculations by the software. So of course, this is not without the pitfalls. There are many pitfalls. The first is this, that you have to cover the whole territory of the MCA. If do not cover the whole territory of the MCA, you're correct, you will get the incorrect graphs. And then the scan duration is important. Of course, if the duration is very long, then the additional burden of the radiation you are giving to the patient. If it is very short, then your graphs are truncated. Then the sampling frequency is important, because if the sampling frequency is very low, then you miss the arterial peak. And then, of course, the noise is important. We have to take 3 to 5 mm of the image slices, but not the 1 mm because they will be very noisy. And again, the motion artifacts are also very important. So this is the example about the coverage. And in the upper row, there is a proper coverage covering the whole MCA territory, but in the lower row, whole MCA territory is not covered. And if you draw the graph from this, you miss many points, and then the graph will be incorrect. So these are the few of the pitfalls, false negatives and the positives. Of course, in the lacunar infarcts, it is very difficult to pick up any change in the CTP than in the watershed infarcts, and likewise in the seizures. And there is a number of the list in which you have the false positive. You should be aware of all this. So this is the example. You can see that this is a lacunar infarct on the right side. Now, if you first see the CTP, you cannot identify any of the problem here. But when you diagnose this lacunar infarct and you go back, you can see that this place, this very small, which cannot be, diagnosed earlier if you see the CTP. So lacunar infarcts are very difficult to pick up at the CTP. So one important point which I would like to highlight here is about the software confusion. This is very important. Now this patient had low cardiac output. That's why the image was noisy. So due to the software configuration, it took the wrong side of the hemisphere. You can see that the problem is on the left side. It's on the left side, but the software took the right side, and so we get the wrong type of the graphs here. So it's the software configuration. You always make it sure that software picking up the right hemisphere. Now, the few words about the analysis. We have quantitative interpretation and the qualitative interpretation. Qualitative interpretation I have already talked about. It's about the CBF, CBV, and Tmax. And then the quantitative interpretation. The quantitative interpretation is the measurements of the volumes, the core and the penumbra. Software can calculate this for you, and our outcome depends upon the quantitative interpretation of the CTP because it tells you about the volumes of the core and penumbra, and of course about the thresholds. So this is again a picture in which you can see that this is the core and this is the penumbra. And core and the penumbra, CBV telling us about the core, and this is CBF, the penumbra, and then this is the Tmax. And you can see that everything is being calculated by the software, and you have penumbra mismatch, and you can decide upon the basis of this your endovascular therapy. So there is a right-sided ICA occlusion, which you can see on the CTA. So after the quantitative interpretation, we have two questions in our mind. Does the CTP accurately predict the good and bad outcomes? Does the CTP accurately predict the infarct, core, and penumbra? So we have a number of the publications already proving that the CTP gives us or predict the good and the bad outcome. And secondly, it also tells us the accurate values of the core and the penumbra. But one point which is very much important here, and I would like to highlight here, is this, that CTP can predict the bad and the good outcome if it is taken as the imaging of the choice after the 6 hours. Because before the 6 hours, we cannot rely on the CTP. So yes, it is a predictor of the good and the bad outcome, but after the 6 hours, not before the 6 hours. Now, when we talk about the thresholds are platform dependent. We have a number of the post-processing platforms. We have Rapid Phosphare, we have Philips Phosphare, we have Braino-Mix software. So it's just like a black box, and everybody is using the different kind of the variables. So what about the ultra early and the late time window? As I have told you earlier about the ghost core, all of you must know about the ghost core. Before 6 hours, if you do the CTP, the whole of the affected hemisphere is showing the core because collaterals are not yet open. So you cannot defer the patients from the EVT therapy on the basis of that core. So that is called the ghost core. So the CTP is not important if you are taking it earlier than 6 hours. It's not the method of the imaging of choice for the acute stroke treatment. But after the 6 hours, then you can depend upon the CTP. Now, in those patients who are who came with a wake-up stroke or who are in the late time window, in those patients, if you look at the CTP only, and if there is a large penumbra and there is a small core, and you said, okay, fine, I'll go and do the EVT treatment, but you don't look at the non-contrast CT, then again it's a problem, because if already there is established hypodensity at the non-contrast CT, then the outcome of the EVT will not be good. So, you have to see, or you have to all imaging together, and at the same time you have to examine the patient as well, and then you have to decide about the patient. So there are few stroke mimics, and you should know the CTP interpretation in these mimics. This is again a case in which the patient had a stroke and the patient went back home with a normal CTA. And you can see the stroke is on the right side when the patient came back and have the CTP. There was some kind of the seizure going on. So it was picked up like this. So these kind of the problems you may encounter in your daily life while there's CTP interpretation, and you must be aware of all these. So next is, there is a famous question and the very, commonly asked question about the kidney function tests. So kidney function tests are not important. You should do your imaging, your CTA, your CTP, your non-contrast CT, and after deciding your endovascular therapy, then you can look for the RFTs, because neurons are more important, nephrons are not that much important. Now, there are few tips by which you can lower your radiation dose, and you should know it, and you can apply, and you can improve your imaging by working on these. So these are few publications about CTA and the CTP. Now, DAWN and DIFFUSE 3 are two trials who use the advanced imaging for this as a selection criteria. And they use the clinical core mismatch and the penumbra core mismatch. And they also extended the time window up to the 24 and the 6 into 16 hours in the DIFFUSE 3. And both of them have shown that there is a good outcome of the patient if they are selected on the base of the of this advanced imaging. So it should be used. CTP should be used, but it should be used after the 6-hour time window, not prior to that. And also there is another paper in which they have used advanced imaging, either MRI or CTP, that is extending the thrombolysis up to 4.5 to 9 hours, or in the wake-up stroke. So my conclusion, CT is the mainstay in the stroke imaging. CT perfusion is used for patient selection in the EVT for more than 6 hours. And the CTP aspects of the technical aspects of the CTP acquisition and the processing are critical. You should know all this if you want to use the CTP. Always use the non-contrast CT. Always do the quality check, and remember your pitfalls. So this is my question. In stroke imaging, the most important is non-contrast CT, non-contrast CT, CTA, time, non-contrast CT, CTA, CTP, or MRI. And I think that the most important is time, because whatever you are doing and whatever imaging you are selecting for your patient, you should be very fast. So you should do whatever you are comfortable with, and you should do it fast. So time is more important for this. So my take-home message is this, that EVT is beneficial in the large vessel occlusion already established after the 2015, and the stroke imaging is very, very important. And the cornerstone of the stroke imaging are the non-contrast CT and CTA. And of course, we can use the functional imaging like the collaterals, multi-phase collateral imaging, and 4D CTA and penumbra imaging. And whatever imaging selection you do, do it fast and do it good. Thank you.
Thank you very much, Dr. Saima, for gold information about stroke, about CT, CTA, CTP. If any colleague has a question, you can ask Dr. Saima. On chat, there isn't any question until now.
Okay. So if you have any question. So if you we have no question, then maybe we can finish our webinar.
We haven't any question on chat. Thank you very much, Dr. Saima. And we hope to see you later, inshallah, in another lecture.
Oh, thank you so much. And it's a pleasure to be with you. Thank you.
Thank you.
Thank you.